my name is Travis McCathie. We're here in Eden Prairie, Minnesota. I'm a certified athletic trainer, a chiropractor, and a manual therapist. I treat mainly runners and I focus on the hips on down and usually treat more tendinopathies than anything. I am a full-time provider and I do travel around the world giving lectures mainly on tendinopathies and how they react with treatments, with modalities such as the Paese wave, and also how manual therapists play a role within the BPS model that we'll kind of talk about when we go on. I've been using the Paese wave now for about 6 years, I think. The first patient I did it on was actually a pro runner who had some gnarly Achilles that wasn't getting better, and I brought him to a seminar that they were at, and we treated him there, and it was the first time that I got a text from this athlete that said whatever he did helped. So I was lucky enough to get the machine into the clinic, and we've been using it ever since with great results. So this is Aaron. He's a good friend of mine. He's a fellow ultra runner, so we run the long, crazy distance, and he's also an amazing coach. And the reason why I bring up the coach part is because, especially with Tenons, you have to worry about people's training cycles and whether or not they're not doing the right progression as far as load. And somebody like Aaron, I can just fine tweak some of the manual therapy components of his treatment and not worry too much about his training regimen. But he's like a typical patient. He comes in, he is running right now. I've seen him for probably a year on and off, I don't know, probably 10 times, 12 times, somewhere in there. He's kind of my typical patient who comes in, they're already moving, they just want to move better. And so that's what we're going to do with this. But he's been dealing with a couple things. He's been dealing with some high hamstring tendinopathy, which is what we're going to treat in here today. And he's been dealing with that a couple months. And he also has some high adductor tendinopathy that he's been dealing with for about a year and a half that kind of ebbs and flows. And we'll talk a little bit of why that happens and some of the treatments that we have used for that. I'm going to try to still hit the same principles of what I would normally do. So for instance, when we do manual therapy, the hands-on stuff, I usually like to treat static and then move to passive motion and then active motion and then resisted motion. And you progress that over weeks. Obviously, you're not going to be watching this for over weeks. So we're going to do a progression like that in 30 minutes. And the same thing is true with rehab. When somebody comes in and they have a really hot reactive tendon, we usually do a lot more isometric training. With here, we're going to do a couple isometrics, a couple isotonics, a couple eccentrics, a functional movement, and then a nerve floss. So we're going to kind of hit everything, but hopefully the goal is just to see progressions. And even with the Paese wave, we're going to hit different angles, so you can kind of see how I use it different besides just hold down one spot and find the painful spot. So the first thing we're going to do is we're going to talk about how I treat every patient. So I know you probably can't see this, but I have a sign up in my clinic. I've had that since about 2005, and it talks about my theory of how I approach stuff. And the first thing I have on there that I don't have on there is structure. So obviously when a patient comes in, we want to understand their structure. Luckily with me, a lot of my patients come in from MDs and they already have MRIs. So I don't have to necessarily worry about the structure, but what's important to know is we don't necessarily treat the structure. If you look at the data on runners, specifically when you look at something like a labral tear in the hip, well, it's 2015, 68% of people who don't have hip pain, who are athletes, have labral tears. So it's a common finding. So if an athlete goes in and they get diagnosed with a labral tear, okay, it's not a big deal. The same thing comes true with proximal hamstring tendinopathy. A majority of runners will go in there without even high hamstring pain, and they'll be like, you have some mild tendinopathy, and we just note that stuff. What we need to do is look at the structure and how it plays a role with this function. So structure, I know he's got a labral tear. With his MRI, he has a mild cam impingement. And I know he's got proximal hamstring tendinopathy. So that's what I'm dealing with as far as structure. And then we move into what I care, which is the functional component. I don't care how you do a functional exam. The whole purpose of a functional exam is to do a test, retest, to basically take something, change it, and hopefully that changes so they get better. A perfect example is running gait. You can take somebody and tweak their gait and get them out of pain, but if you do a follow-up study on them, they usually revert back to their old gait, which is fine as long as they're pain-free. So I used to put everybody on a treadmill, evaluate their gaits, break it down, and I used to sound really, really smart by doing it, but you soon realize that every runner kind of has the same thing. work on your glutes so you don't get a hip drop. Don't do a crossover so you don't get any adductor stuff. Shorten your stride, strike underneath your hips, so increase your cadence. Don't cross over. So it's the same stuff over and over and over, and you can see it with other movements. I personally use a functional squat assessment. So when we did a functional squat assessment with him, I'm not gonna have him do this stuff, but he shifted over to the right, which means that either he shifted into a side of weakness, which would probably be his glute med, or he shifted into a side of tightness, which is usually his adductors. And honestly, he probably has both of those things going on. He had a right arm drop when he squats, which technically isn't a big deal. Are you right-handed? Not that big of a deal. Everybody has a dominant arm drop, but if it was opposite, I would note that. But the only reason why I note that too is because one of the things we're gonna work with high hamstring is the psoas. So you could argue if somebody drops the right arm, maybe we should work into the lat and the psoas area. And we do, it's just, again, I doubt I'm gonna change that on a functional position. And then some other stuff that we do, any type with a high hamstring, we see the data with high hamstring, people go into more of an anterior tilt. So some of the exercise we do put him in more of a posterior tilt, and then we give him cadence work, since that is right now one of the main gait things to do with proximal hamstring. So we just have him, whatever his gait is, we give him cadence cues to increase his stride length. So that's function. Then we get into mobility. With runners, I like what's called a joint by joint approach, which means every joint should have a function. Ankles should have motion, and knee for the most part should be stable. Your hip should have motion, your back should be stable. So when I look at a runner, my goal is to put motion in the joints that should be moving and create stability in the joints that should be stable. And then we look in the overactive part. So the overactive, basically, when you just look at somebody with high hamstring stuff, obviously their hamstring's gonna probably be overactive, and underactive would be the glute med and glute max. And then we work at facilitation. So the facilitation muscles, and this is all what you're gonna see in this next 20 minutes or so. Facilitation, you see 1,000 people, what do they tell you to work on? What muscle? Putting you on the spot, Don't let me down in the sun. The glutes. Everybody gets told to work on the glutes. So with a runner, for the rest of your life, you need to do some glute activation. And it's because we run in a front plane, we hardly do anything in the lateral plane, and glute med is a lateral mover, right? So it's an abductor. So for the rest of your life, you do band walks, you do monster walks, you do sideline leg raise clamshells. He knows that stuff. He should be working on that stuff, right? Yeah. Okay. Once we get the underactive muscles to start engaging, we start to look at an optimal movement pattern. And that's what's tough. Like, what is an optimal movement pattern? Just because if he's a heel striker, does that mean that's not optimal? I disagree with some of the stuff. With him, I think the most optimal thing we're gonna do is just make sure he doesn't have a crossover gait and then work on his cadence. I think that's gonna be the best thing you can do to optimize your running. And then strength and power and endurance. So the last thing on my board, and the reason why is most of our PT clinics that we have here, they're low tech stuff. We don't have big platforms to build strength. That's the stuff he's gonna do on his own. And we'll give him some stuff to load the tendon today, but ideally I always encourage somebody to work with either a personal trainer or do lifting. If you're interested in proximal hamstring stuff, by far kind of the gold standard paper that we have right now, one of the gold standards, we have a lot of them, but JOSPT 2016, this looked at proximal hamstring tendinopathies and how to treat them. It's based on Jill Cook's model of loading a tendon. And so what they did in this paper, which is really nice, is they looked at a step protocol on rehab in a 3 to 4 month progression. So you do these 4 exercises. Once they become pain-free, you do these next 4 exercises. Once they become pain-free, etc. But the cool thing about this paper, if you read this paper, of course, it's always at the end. It looks at modulating pain so people can load tissue. So you'll get people in here who say, I can't even sit down. I definitely can't do a deadlift. I can barely push my heel in without creating pain. You need to start modulating pain so they can load it. And one of the biggest things that we have, according to data right now, is Paese wave. So it's kind of nice that they mention it in here, but this is what the main reason I use this for. It allows me to allow people to start loading stuff a little bit more. Okay. So the first thing we're gonna do is we're gonna do just a couple measurements here. So I'm gonna grab a thing. I always measure people's internal and external rotation on the hips because those are my main, I need those motions and it gives me an idea of how I'm gonna treat. There's a couple ways to measure it. We look at functional motion over structure. So as soon as he starts to cheat motion, you can kind of see how his upper back moves. That is his motion. And all I'm doing is looking for differences right now. Hopefully you guys know the normal measurements. The biggest thing that we look at is somewhat symmetry. When you work with shoulders, symmetry is impossible. You're always going to have the dominant arm is going to have a lot more external rotation. The non-dominant arm is going to have more internal rotation. With runners, you want symmetry specifically in hip internal rotation. Hip internal rotation is the most important motion for a runner because it allows your hip to go into extension. So if he lacks hip internal rotation, and he's about 4 degrees off, which is honestly really minimal, but what happens is part of your capsule, your ischiofemoral ligament, a big ligament in the back of the hip, actually pushes you forward. And so what happens is when you go into extension, instead of your femur gliding, it's going to start hitting the front part of your hip, which is why a lot of our runners have the anterior superior labral tear. It just jams over and over and over. And so they start to shorten their stride, or what they do, in his case, he opens up his hip a little bit. And when you open up your hip, you start to open up your hip in a flight phase, and when you go into a stance phase, you'll start to go into a valgus position. So your knee caves in, so then you're going to load your adductors over. The question is what comes first. With him, I think it is some of this hip mobility stuff. There is a lot of debate on this. Obviously, chiros like to do manipulations. There's nothing wrong with that. I like manipulations. I like mulligan techniques because they're three-dimensional. Whatever gets the job done. If my goal is to increase internal rotation by 4 degrees, I just want to make sure I've changed the range of motion 4 degrees. So when you do mulligan techniques, it's pretty straightforward. Three-dimensional. What I'm going to do is put a little pressure posterior into his capsule. I'm going to do a little lateral glide, and then I'm going to work his hip in the internal rotation. And I can work passive motion, and I can have him actively assist me as well. But we're just going to do passive right now. You okay? Mm-hmm. I think I've done this every time you've came in, haven't I? Yeah. Should not hurt. Mulligan providers are really big on don't do anything in painful areas. I'm not 100% like that. Sometimes I do push people into a painful zone, but it really depends. So when you do mobility with movement, sometimes people do 3 sets of 10. I usually just try to hang out in the capsule for a couple minutes. Again, I'm just trying to put input into it. I'm doing so many other techniques that it's all about just putting the right amount of input in the tissues. So hip mobility, ankle mobility, same thing. We do just a little bit of mulligans on his talus here. And this is where sometimes in a normal treatment session, we would be working a little bit longer. It might take me on the first or second visit 15, 20 minutes of mobility work. With him, since he looks pretty good with all these motions, we're only just going to do a little bit. So once we work mobility, we're going to give him just a mobility exercise quick to stabilize. This is a mobility exercise. So this is the reverse clam. It's a position that a lot of people don't do. Hold on, I'm going to move you back a little bit. I like to do some exercises with a metronome. There's a lot of data coming out that looks at externally focused rehab. So if he's listening to a metronome at a beat of 60, he'll go up, down, and now the only difference is keep that gap, keep that hip forward. So you can see he's working hip internal rotation now. And with this, we usually do just 1 minute or a set of 30. Tired?
All right.
Okay. All right, we'll condense it down. That's good. So mobility stuff, pretty straightforward. We could maybe do some standing ankle mobility too. We could do some standing hip mulligans. Like I said, the whole idea is just put input into the joint. You guys can kind of see how I look at just putting input into that joint. The next thing we're going to do is what most people come to see me for, on your back again, is the overactive stuff. So what is overactive? So I use a couple different techniques. Passive release, active release. I've been an active release provider for a long time. I don't have a preference. Strain, counter strain, Graston, dry needles. I don't really have a preference. Again, it's a goal system. So whatever the patient seems to tolerate. Some patients I can needle, some patients I can't. Some patients don't just like to be touched, and you just kind of have to deal with that. So the things that we're gonna work mainly with him is we're gonna show you the difference between like doing some static work, some passive work, and some active work. And I'm gonna mainly focus on his adductor and hamstring since that's here. But just so you know, normally with treatment here, we'd be working his psoas a lot as well, his whole adductors, his 6 hip external rotators, and then obviously into his hamstring. And if somebody has pain in this way with their hamstring, we tend to follow it all the way down the nerve. When I teach manual therapy techniques, I say there's 3 areas that you have to hit. One is the symptom point. So where they touch to where the pain is, you should probably put input into that area. Otherwise, they're gonna think you're crazy if you're like just working up away from the pain. Number 2 is the line point, which is what I call a peripheral nerve point. So if you have soreness right here, let's say your posterior tib, you not only treat your posterior tib, you should probably be treating the tibial nerve that goes through that, and then you can follow that pathway all the way through. And you should also treat the segmental point, which is where that tibial nerve comes out. So that's how I look at stuff. When Aaron comes in here, we do a ton of body work, and we work basically this whole kinetic chain. Again, if you follow Meyer's work on the anatomy trains, that stuff's fine as well with him. You know, you could work basically a whole lateral line or a sling pattern. Again, you're trying to do a test, retest to get something to change. So we're gonna start by just doing a little bit of static work so I can kind of feel around in your hamstring. And then we'll have you flip over so I can do some passive work, and then we'll do some active. Makes sense? So go face down here. So I always start static, one, because it gives me an idea of how tissues feel. And it also desensitizes the patient. And so I don't have to start with something that's really aggressive to them. Again, a million ways to do tissue stuff. One of the biggest things we see with tenons, right, is doing fascial manipulation. So doing 3 to 4 minutes of aggressive cross-friction massage. Great, awesome to do. One of the big muscles that's often overlooked, specifically with high hamstring stuff, is that guy right there, which is the Quadratus Femoris. It's, I think, the most important muscle to work. It's one of the reasons why our glutes disengage when we run. I'm gonna lower that for you. So again, I know he's a little bit more sensitive over the Quadratus Femoris. Because of that, I'm probably gonna Paese wave there tonight instead of just pure high hamstring. What we're gonna do is we're gonna start working some passive motion, both on his medial hamstring in here, and then we're gonna start working some motion into the Quadratus Femoris as well. So again, the people who do a lot of passive motion, the reason why we do it is you'll get neurological tension before you get structural tension. So when people actively move, you're going to get a blockage way sooner. That's why if you have somebody who can't turn their neck one direction actively, but if you get them to relax enough, you can turn them a lot more. Or if you do it when they're unconscious, they have a ton more motion because it eliminates that neural tension. So now I'm going to have him actively help me. Yep. And hold for a couple seconds. And back. Go again. And back. Yep. So we're going to work just a little passive motion here, and I'm going to do them in this position just because it mimics that same position of that reverse clam we just did. And then we're going to get the actual high hamstring point as well, which if any of you have taken like any of the ART courses, you've probably seen some of these positions. So I don't love to push him a ton in hip flexion because the test that we look for FAI of the hip is, you know, the fader test, so flexion, internal rotation, adduction. If I crank him too far in that position, it does create soreness. So if you notice when I'm doing this, I'm kind of moving him out a little bit just to open up the hip a little bit more. So are you okay? Mm-hmm. It doesn't create too much soreness. This is when I usually use the Paese wave. One thing I am big on is how you communicate the Paese wave with patients. And you got to come up with your own way to say it. Everybody always asks what it is, especially the first time they use it. It's kind of a intimidating machine, especially if they've heard it go on. And what I usually just tell people is it looks at mechanotransduction, which is a fancy term for meaning that I'm going to put mechanical energy into tissue. Your body is going to create a biological, biocellular response, and that is going to change, hopefully, how your body is perceiving pain and how the tissues can respond to load. I don't say things like this is going to completely regenerate your tendon. So we get people in here who say, I have a 30% retraction of my hamstring, is going to make that 100% normal. No. But it doesn't matter. Like, you can still get pain-free and fully functional and still have that 30% retraction. That's the goal. If they really want the sciencey stuff, I usually say it responds to certain cells. So when we hit certain cells, specifically like a tenocyte, it usually starts to vibrate, and sometimes that's what creates a little bit of soreness. And then I usually hang out there for a while until it basically desensitizes, and then I find a new position. One thing I do with my people is I change up positions for them. So I use Paese wave, how I use my manual therapy model, which is static first session. So I usually do 1 to 2 sessions static, meaning that he's just going to go face down. I'm going to go to the symptomatic point. He'll even point to it, and then I do the rest, and I kind of let the machine find it for me, and I kind of hang out. We're going to do a little bit there on you today, just so they can see. And then what we're going to do is we're going to put him in different positions. So since his biggest complaint off camera was sitting after a long run into a chair, this is the most compressive point for a hamstring. I'm going to do Paese wave in that position as well. And you can do it a couple different ways. You can just bend up his leg. You can work into rotation pieces. What I'm going to do is I'm going to do static. I'm going to start working a little bit of passive motion for that rotator. And then I'm going to have him go onto the side and go at 90 degrees, and we're going to finish it off there. I am going to do a couple pulses on his adductor as well, because again, we need to treat that as well. And what we're going to do is we'll stick with what the research says, which is basically about 2,000 impulses into those areas, and it's patient comfort. So what I tell patient is, I want you to feel like a toothache sensation, like a mild ache, but I don't want it to hurt. You know, if you look at the pain, you know, maybe a 2 out of 10 tops, but for some reason it starts to hurt, just let me know. What I'm going to do with him is, just because I haven't seen him in a long time, is I'm going to start with the 15 head. And the only reason I'm choosing the 15 head here is because what I'm going to do with him is I'm going to hit more of that Quadratus femoris on the side, not quite as meaty as if I was going basically through the glute max and trying to get the piriformis. Then you can use a 20 head. In this way, I can keep that same head to work his adductor as well. Really, it comes down to preference. Sometimes I'll have planners who come in who I'm doing 15 right away, and sometimes I have hamstrings where I'm doing 10. And my biggest gauge for patients on that is how they feel that next day. Ideally, you want a little bit of an analgesic effect. You want people to say, you know what, I actually felt pretty good. The next day, mild ache. But what I don't want is for him to text me or call me and say, what did you do? I can't sit in my car. I definitely can't run, because then he's going to be mad at me, and I got to explain that I probably did too much of something, whether it was my work, the machine's work, or rehab. So the nice thing about this unit, in full disclosure, I used to have a radial unit for about a year and a half before I met them. And the radial head doesn't give you feedback as much. So I don't know if anybody has used a radial head, but it creates a mechanical pulse. So it hits tissue over and over and over. So no matter what, they're going to feel the tissues getting hit. And so it's hard to get patient feedback of being like right there, right there, right there. When you use the focus units like this, you get a lot more patient feedback. So I always try to start in a place that I know that's relatively going to be pain-free, and then work my way into areas, and they can give me feedback. I didn't warm it up for you, I'm sorry.
It's okay.
I usually do. So we're gonna start, and again, kind of based off his previous settings, I'm gonna get up the intensity to about 10 or so. High hamstrings, the most I'll go is 14s usually. I usually try to be around the 8 to 12 range as far as a therapeutic dose. I used to really care that I was in the therapeutic dose of stuff, but now really what it comes down to is patient results. As long as they're getting better, I'm fine with it. That's the most important thing. Feel anything?
No.
Just let me know if you start to feel something, okay? So the one thing with the Paese wave, do they need to feel something? No, but that's a nice feedback thing where you can start to search tissues a little bit more. So once you treat a symptomatic point, if they're doing okay, you can start to go through different areas, and you can also adjust intensity a little bit. His last setting, he was up to 12, which we might go back up to 12 here. If you notice what I'm doing in the static position here, we change angles as much as we can, you know, especially if you're targeting fascial tissue, superficial tissue. It's a spider web, right? So you have to hit in every single position. One of the biggest questions I get, especially with high hamstrings, is people will talk about sensations in the front of the hip. It's normal, it's fine, it follows the periosteum around that hip, but it's a relatively common thing that patients will tell me. I'm gonna keep you here. I'm not gonna go higher though, but I'm gonna stay on the symptomatic point. So we're gonna do about 750 here, and then I'm gonna move over to the Quadratus Femoris here in a second. So I'm just putting it in a shortened position, and I'm gonna work this outside of this hip here. Okay there?
Yeah.
Okay. So the same thing here, I'm breaking the hamstring up in 3 different locations, even though it's all really close to one another. So again, I'm probably gonna go to about 1400 or so on this side of his ischial tuberosity, and then we're gonna put him at the side lying position at 90 degrees. And if somebody says that's a really good spot, a good ache sensation, which is sometimes really common, I just hold there, and what it's gonna be like is, I'm sure you've known this with your patients, it's kind of like a roller coaster. All of a sudden it starts to diminish down, and all of a sudden it pikes back up again, and then goes back down, and sometimes you get off it, and you go right back to the area, and it lights up again. Is this spot more sensitive than the...
Yeah, that's the
Yeah.
spot.
So the reason why I like to do this is, especially high hamstrings, by far the biggest complaint is a compression point of the hamstring. So anytime you look at a tendon, you look at tension points or compression points. Proximal hamstrings are more tension points, so it kind of compresses up underneath this when this hip is flexed. This is why a lot of people, it hurts to sit. So I do like to modulate pain in the place that they feel pain the most, which is in this position here for him right now. This one you have to be sometimes a little bit more cautious with because we're putting the tissue on stretch. Sometimes it's more sensitive. So with him, he's gonna be fine. It wasn't that painful, so I'm gonna keep it here, but for some reason, if it is, just let me know. I'll take it down a little bit. Because he isn't super reactive right now, besides his quadratus, which I could probably tell when we did the hands-on stuff, I'm gonna keep scanning around and just keep facilitating all this tissue around here. Because he isn't super reactive right now, besides his quadratus, which I could probably tell when we did the hands-on stuff, I'm gonna keep scanning around and just keep facilitating all this tissue around here. If I get a spot, just let me know. Otherwise, I'm gonna just keep moving. So in a perfect world with him, and we might do this once we're off air, kind of plan how we're gonna approach this as far as treatment. I'm probably gonna start searching through different areas. So I think what we'll probably end up doing with him is do about 2 to 3 sessions, localize, and then we'll probably start going through his whole hamstring and then up through the whole hip. You know, there's 5 other hip external rotators to work with, and just again trying to change symptoms and see if we can get a positive approach. So if you're doing the same thing over and over and people aren't changing, you're probably not helping them anymore. So you can either send them on to somebody else, or you can just change up your approach a little bit. There's nothing wrong with changing it up. So it doesn't matter if you go over, no. Big areas, I sometimes go up to about 3,000 impulses. I personally never put more than 4,000 impulses in. And the reason, I have people who come in just for the Paese wave, and they ask for more in different locations. Like today I did a high hamstring and an Achilles. I did 2 in each. And I do think it's super safe, but I always tell people, I think like anything, too much is not good. So if I did an hour of just elbow and made somebody sore, it's just gonna make them sore. If you did 100 pull-ups instead of 10 pull-ups, eventually you're just gonna get sore, but we see a diminished return. So I gave a talk about Paese wave with a podiatrist who uses it, and he showed a great graph of being this zone. So we have a treatment zone like a bell-shaped curve, that's where we wanna be. But a lot of patients come in and say, just crank it up, you know. If you go too high above patient tolerance, all it's gonna do is just make them sore, and you're just gonna have to deal with that for 3 to 4 days. If you don't do enough, it's always easier to build into stuff. So I stick it at 4,000. If they have multiple complaints, I just hit 2,000 on each side. With him, I would probably, if it was just high hamstring tonight, I would go higher, but since we're gonna target that adductor as well, we're gonna do 2,000 on that part as well. I use a lot of gel. I use a lot of product. Don't judge me for that. I'm actually going to keep the same. So I'm going to keep the same depth, so 15, and I'm going to keep the same intensity too. Yep. Right in there. Yep. I'm going to hang out here for a little bit. Okay. Tendons, when to know when to use this. It's Jill Cook Works. Look at, if you Google Jill Cook's work and look at her work on tendinopathies, they have a nice little graph that talk about whether it's a reactive tendon on one spectrum, or a tendon that's in disrepair, or a degenerative tendon. And the only research that I've seen where this hasn't been super beneficial is a reactive tendon, which makes sense. Somebody comes in with a really hot new tendon. The last thing you probably want to do is stick needles in it, do Graston on it, do Paese wave. It's already oversensitive. You got to just get it to calm down. The disrepair phase and the degenerative phase is where this is amazing. And I usually say that happens very soon. So with me, and this is my preference, I don't have data. You still doing okay? Yeah. I usually don't touch. If somebody emails me and says, I just went for a run, my Achilles, I can barely walk, when they come in, it's usually 3 days. So in a normal inflammatory cycle, right, 72 hours, I let the reactive stage calm down before I do anything that can stimulate basically almost a pro-inflammatory response, which that's how I go by stuff. But yeah, after 3 or 4 days, if they can tolerate it, I think it's helpful. I do it on like hot shin splints and medial tibial stress syndrome and stress fractures. I just do not do it on reactive tendons. So we finish our 4,000 impulses. We basically finishes our calming down our overactive. The facilitating underactive, I'm not going to do with him because we've already shown him that stuff. But for him, we kind of talked about this. It comes down to just basically doing the muscles that assist. So a lot of it comes down to glute med, glute max, bridges, Jane Fonda's, the reverse clam even fits in that, the normal clam, band walks, all that stuff. I say that's facilitation because you can do band walks every day for a year and it's always going to burn. You're never going to build a lot of strength with that. Versus if you go in and actually load tissue, that's how you build strength. I think everybody agrees with that stuff, but I don't want to knock on the facilitation stuff because I think it is really important. It's just something that he has to continue doing on his own. And there's only so many ways to facilitate muscles. What we're going to do with him then is we're going to progress to the next thing, which is the optimal movement pattern. All right, loading 101. So after we do all our manual therapy, after we do the Paese wave, the whole idea is to get them tissue loading to adapt, so hopefully they don't have to see us for the rest of their life. My protocol, if they're really painful, isometrics. So the data on isometrics, you do 5 sets of 30 to 45 seconds, depending on who you read. And so if he was not able to run, we do isometric training. And isometric could be as easy as they just resist you manually, or they just do a bridge hold. They just push into a wall. You can get into a position, and they do that throughout the day as many times. So he's beyond isometrics. We're not going to demonstrate isometrics. We're going to get into an isotonic exercise, so a functional isotonic exercise. So we're going to do, since he has an adductor and high hamstring, we're going to give him a multi-directional slider plate lunge. And so what we're going to do with this is it's all about knee tracking, right? So when we load, we don't want our knee to go in, and we just want to work different positions here. So when he goes into a back position, this is all the stride angle that we need. I want him to consciously think about tightening this hamstring and pulling himself up, so he's getting that hamstring contraction to it. But I'm also going to have him work into the adductor as well. So when he does adductor, he's going to go to the side. And then to get rotator, he's going to cross his midline back here, making sure, again, that knee does not go in, and just work those positions. So he can load this. Yep, you keep going. So again, I haven't seen him in a while, but eventually we'll give him some weight and have him start building up load in this. Right now, I just want to see how he responds to our first treatment again in a while. How you doing? Ooh, what's that knee? Pain?
No.
So pain with exercise, everybody sometimes asks me, what if it hurts? I'm okay with it as long as it's, again, that 1 or 2 out of 10 pain scale. But if you have a patellar tendinosis, if you do just a little mini step down, it's going to hurt. But that is a very functional exercise if they can't walk downstairs. So I am okay with loading into pain as long as it doesn't make them worse. So the next thing we're going to do is we're going to look into like an eccentric loading. And the whole reason why I'm showing this is I think as providers, we sometimes think tendons only respond to eccentric loads. And I think that's been kind of disproven with the research lately. A combination of movements is by far the best, but eccentrics are further down the line. So in general, isometrics more for pain, isotonics more for movement, eccentrics are more for almost like tendon change. So that's kind of the later stage of the tendon disrepair. And one of the best exercises for high hamstring, and he's going to do basically an eccentric load. So I am trying to push the treadmill back this way. I'm not letting it happen. So it's almost like I'm trying to resist it like this. And you're going to do a set of 15 with this. And when I do eccentrics, I usually do 3 sets of 15 and give it about 1 to 2 minute rest in between. For the sake of this, he's only going to do 1 set of 15 with it. And you can see this is great, especially for a runner who overstrides or has a low cadence, because we know that the hamstring decelerates us going into a stance phase. So if they're striking in front of their hip, that's where they're going to get a ton of load on their hamstring tendon. This mimics that load and hopefully makes it so they can run pain-free. But whatever his cadence is, don't worry about a number. Before, we used to always try to get people at 180, 185. Now what we really want to do is take whatever their cadence is and add it about 5 to 10%. And I love cadence workouts. So instead of him doing a fartlek run, he can go out for a run, do his cadence for 2 minutes, forget about it for about 2 to 3 minutes, and do 3 to 4 sets of a cadence workout. We're gonna move into basically more of a dynamic eccentric work now, and one that also flosses a nerve. So remember how I said I'm a big peripheral nerve guy, so we're gonna work into the sciatic nerve. But what we're gonna do with this is we're gonna work position. So we're gonna keep our shoe on, this leg stays bent because it keeps you in more of a posterior tilt. So otherwise, if you're here, you start to arch your back. But what you're gonna do with this is straight leg, you're gonna go down and then control it back. You don't have to go super slow, but what I don't want is ratchets. So just work down and come back. What we're gonna do is, just for time's sake, we're gonna do 5 here, and then the hard one, bent into that position that's kind of sore. You're gonna push out and then eccentrically come back. Controlling that knee, I don't want to see you doing like. My idea of rehab, again, opinion stuff, right? Now we're starting to get into opinions, but hopefully that's what some of you are tuning in for. I like facilitation stuff after a run. And the reason why is if you go to mile 20 of a marathon, that's where everybody's form starts to fall apart. And people will come into your clinic and say, I feel fine for mile 7 through 10. And once I get to 12, I start falling apart. Well, that's where our gait changes too. And especially a guy who's doing, 50 Ks and on and above, we need to, so push out to here and then control back. So I like his clamshells, band walks, Jane Fonda's, all that stuff, single leg bridges after runs. Strength training, I like separate, so I don't like running the day of strength training. This, I like just when you're warm. So people should be doing this when they're warm, not the first thing they do when they get up in the morning. But this is one of my favorite exercises for a runner. This is a PT who works with the Nike Oregon Project. I've stole it from them, so it's on YouTube. It's called the Hot Salsa. I used to do a modification, but his is just way better, so I'll give him props to that. But you're going to take a weighted ball. It doesn't matter the weight. 10 to 12 pounds is usually sufficient. But what you're going to do, and sometimes we put a piece of tape down, especially with runners who have a crossover gait. He is not that bad, but what we're going to do is we're just going to do a lunge, and we're going to break it up into 4 sequences. So 1 is a little modified lunge. Perfect movement here. You're going to reach. That's 2. Number 3 is you're going to pretend like you're diving into a pool. You load that front leg, you come in to a deadlift, and then you come straight up. And then we walk down the clinic. With him, he's going to step back just so we stay in the frame, and then move into the left leg here. And I'll help you. So think of 1. Yep. 2 is just to reach out. 3, dive. There you go. And I like this because it's a single leg loading. Keep going. He's working a ton of proprioception. So especially with our aging runners who lose balance as we age, this is a great exercise to do. But it also puts you into an extreme motion again. I know his stride angle is not this long when he runs, but if we can have him adapt to those loads and more of the extreme ranges, then when running, should be relatively pain-free. Good. So this is how we progress with running. So again, kind of just to review a little bit. Take in mind of their structural limitations that they might have. So if somebody comes in and they only have 10 degrees of hip motion, which is of hip internal rotation, and ideally they should have 40 or 45, but they have a huge cam, you're probably not going to get 40 or 45. You just try to stick with the structure that they give you. Try to look at some functional exams. So do something that you can test, retest, and see if objectively you're reaching your goals as a provider. Work mobility. So the joints that need motion, put motion in. The ones that should be stable, you figure those out as well. Overactive. I don't care what you do to get the overactive stuff to calm down. Underactive, start facilitating those muscles, train an optimal movement pattern, and overload with strength and endurance. Then obviously the tissues that respond best to Paese wave, it's really kind of endless. Most of our data right now is on tenons, but you can follow fascial pathways, you can follow mid-substance belly. It's pretty endless, but with this talk with tenons, I'd probably wait 2 or 3 days to get them out of that reactive stage. But if you have even a completely full-blown degenerative tendon with retraction, you can still make that function at a high level with way less pain with the Paese wave. I see mainly runners, and honestly, there's a reason why people don't like to see a lot of runners. It's because of these chronic, annoying injuries that are actually really, really hard to treat. So most providers kind of get scared when they have a runner, and they are scary to treat unless you surround yourself with tools that basically help you treat them. The Paese wave has, one, helped my practice because I offer it when not many people are offering it around, and people will seek out things that work. So people will travel from far and away just to get something like this done. It's non-invasive, so it's for the most part pain-free, and it allows us to progress an athlete, especially a high-level athlete, way faster than we can with any other modality on the planet. And I think finally research is catching up to that, where I can stand in the front of a room with a whole bunch of well-known orthopedic surgeons and say, one of the things we utilize to treat Tenons is the Paese wave, and they are aware of the research that's happening with that, and they are happy to keep sending patients our direction because of it.